Good afternoon. My name is Eugenia Oviedo-Joekes, and I think I'm the only one that can pronounce it, so I'm going to say it myself. Thank you very much for inviting me. Do I reach in? Oh, okay. Yeah, no, it's okay. I guess I'm too tall or too low for this. Thank you so much for inviting me or us everywhere I go. I present the research of the team. So if I say I, please remember there is a huge team of 15 years of doing research in Vancouver, University of British Columbia. In the 1980s, a huge epidemic of HIV flooded Europe. As one of the responses they had was to be able to reach almost 80% of the people that were using drugs by injection with long-acting oral opioids, mostly methadone, but in countries like France was buprenorphine. Then in the 90s, rich countries like Switzerland were still being hit by another heroin epidemic. And even when they are having safe injection sites, methadone, and many resources available to them, they were still very beautiful and lovable young people injecting in the streets. And they decided that if that was the medication that they were using in the street, they would open sites for them to provide them a safe, medically prescribed, pharmaceutical-grade heroin. It's called diacetylmorphine. So that was in the early 90s. Since then, many countries, including the US, have been trying to prescribe diacetylmorphine. And some countries follow, including Canada. And today, in Canada, we are able to prescribe pharmaceutical-grade heroin, diacetylmorphine. And in a second clinical trial, we are prescribing another injectable short-acting opioid that is, you may know it as Dilaudid, that is hydromorphone. So today, in Canada, we have several options for people that cannot stop or do not want to stop using street opioids. We have methadone, we have buprenorphine plus Suboxone, and we have slow-release oral morphine, and we have hydromorphone. And in certain places, you can access, with a bit of help from Health Canada, diacetylmorphine. So I have been involved in too many clinical trials trying to bring these medications and bring evidence. We have been well published, and I say that just to make sure you know we have the evidence to back us up. And what we have learned is once we see the patients in our clinics, because of the nature of the medications we provide, we see the patients at the very far end of the continuum of care. Means those patients that by the time we see them, they have been injected in the street for 20 years. If there is something we see is the patients have felt nothing, it's the system that has failed the patients. We see many training opportunities for the system on how we should care the patients for. We learn to listen to the patients. 30% of our population that reach this treatment are from the indigenous community, when actually only 5% of our population is indigenous. So we learn that we are over-stigmatizing our indigenous folks. We learn how the cultural genocide translates to the people that are using street drugs. So we learn that we need to include in our curriculum culturally safe ways to treat. And culturally safe means that we need to look who we are, the ones we provide treatment, not so much to what's the people that is coming, because people don't feel safe when they come to our offices because we are very different and we don't treat them in the way that they would like to be treated. Because 50 years ago, we used to lock them when they had tuberculosis and take them away from their families for years. So yeah, there is a precedent for why they don't come to treatment. We learned that probably between 30 and 90% of the people we reach, they have childhood traumas physical and sexual abuse and neglect. We know that emotional neglect causes almost the same amount of damage in long term on how you build relationships with people and how you care about yourself than physical abuse. And we have 90% of our folks present to treatment with childhood abuse and neglect. So we learn that we have to include trauma-informed care, because we need to learn how we are and how we relate to our folks. And also we learn the shared patient decision-making when we allow physicians to have 5 medications they can choose from. And the patients feel less stigma. We have talked about stigma, how stigma looks like for our folks. When they come to our clinic, they have 5 medications they can discuss with their physicians. We're talking about ideal training because we have a very small island of luxury today in a few clinics in Canada where we can practice how this will look like if you will able to have more options that are all of them evidence-based, with several randomized clinical trials, double-blinds, published New England, JAMA Psychiatry, British Medical Journal. It will look like when you come, the patients feel like they are not judged on what medication the physician will, as we heard today, very wise and compassionate people saying, we will want the patients to take the medication that we were trained and know might be the best for them, but we don't want them to leave without medications taken, because we know that if there is no medications, most likely they're not going to do well. People come because of the injectable short-acting medication, but nothing else we do is about the medications. It's about caring for people. So when we are trying to talk about training, we talk about training a full spectrum of patients' needs and meeting people where they're at. Sometimes from the healthcare system, we are really far to understand what people need because we have not been trained for. And I heard very interesting and beautiful ideas. Yes, students are now today in a very social justice mind, and they want to know. They want to be part of this. So if there is something we can share from a very wild idea of providing injectable short-acting medications to patients is it allows an idea of ideal way of negotiating a better care for our patients. Thank you.